Pro Vice Chancellor of Medical Sciences at Geetam deemed to be University in Visakhapatnam and member of National Teacher Training Center Core Group at JIPMER and Head of Department of Medical Education of JIPMER on the topic Handling Emotional Responses and Difficult Scenarios.
Share some of my ideas on handling difficult scenarios and emotional responses. It's something which I handle on a regular basis. Besides, my work is much more easier since Professor S.P. Rao has spoken most of what I want to speak. So it sort of set the stage for my talk today. Now, the main objective of this session is to equip the medical educators who are here with some tips to teach and model effective strategies for these challenging interactions. You'll agree with me that anything which evokes so much of emotions or difficult scenarios are very challenging interactions. So I have sort of divided this into four. The first thing is we'll try to understand what a difficult scenario is, and then we'll look at some of the emotional dynamics in clinical encounters, or it might be teaching encounter also, or it might be an administrative encounter. And then some of the core communication skills and structured approach which you can use, and then finally about how to teach and model these skills. So let me ask, which domain do you think this session is on? Focused on which domain? Yes? Yes, affective domain. So I am teaching the wrong way. Affective domain should not be taught like this, so that's just to make sure that all of you are attentive. So the affective domain has three components. Any aspect of affective domain also will have a cognitive component, a behavioral component, and the affective component of it. So you know all these things, how it makes. Affective component is how you feel, the behavioral component how you act to what you feel, and of course the cognitive component is what you think. So you think something and that affects the way you feel about it, and therefore you act. So that's how this thing is taken on. So the question is this important? Handling emotions in difficult scenarios is not a soft skill. If you think it is a soft skill, it's wrong. It's a core clinical competence. So we need to teach it because we have to equip our medical students, our postgraduates, how to deal with this. Just the way we will be teaching a clinical skill. So don't think that this is something which is a nice to have thing. It is a must have skill. And why does this matter? Because obviously in medicine a lot of emotions come up. Okay, it is emotionally charged. Illness, whether they can pay for it, whether there is suffering, there is loss, uncertainty, all these things bring up emotions. And also emotional outbursts are common. It's very common to see a nurse yelling at a patient, or a patient yelling at a nurse, or a doctor yelling at a patient, or a doctor yelling at a nurse, and all these things. We also need to have or teach emotional resilience, because unless we teach students to manage their emotional intensity, because that is what is necessary in today's 21st century, also empathy and professionalism and all that. So it does matter. So this is something which is very important. And so what are the common difficult scenarios you will come across as a clinician or a teacher or an administrator? Forget breaking bad news or deciphering bad news. What other common scenarios do you see? Anyone like to add? Anyone? They're busy taking photographs. Anyone wants to say some difficult scenarios you come across? When a student is not good, disclosing medical errors. There was a session today on medical errors and patient safety, giving negative feedback, and not just dealing with dying and death, but also supposing you want to transport somebody who's not yet dead, or it is a do not resuscitate orders or something like that, witnessing injustice in healthcare. So a lot of things, conflict with peers, conflict with staff, patients, all these are difficult scenarios because emotions come up in all this. And of course, they impact all the three stakeholders. So the stakeholders may be patients, or it could be students, or it could be faculty also, healthcare professionals or administrators, whoever is on the other side, and it also comes with families, like Dr. S.P. Rao said. Parents are involved when you are going to talk about the students, isn't it? So all these three are involved because the success of an encounter depends whether you are able to recognize the emotional cues in patients or in parents or in students, and also the emotional responses, how you as a healthcare professional will respond. So of course, we love to give a structure to everything, but remember, structure is just there, out there. It doesn't mean that you have to stick to it, as if you are driving a car on the road. It doesn't always happen like that. So the first thing is stay calm and be present. You have to know to regulate your own emotions first and be fully present. When I say be fully present, it doesn't mean you are just physically present. Right? It means that you are there and you are listening and you are fully focused. Okay? But this may not be possible for all situations. If there is violence, let's say there is a group of people who have burst in, some villagers have burst in, or you find somebody has wielded a knife or a gun or something like that, I would say leave. There is no need for you to be present when there is violence. This is something which I always tell our postgraduates, especially in AIIMS Bhubaneswar. When I was there, we used to have this huge problem. So I used to say that you don't need to stand there and allow yourself to be scolded or embarrassed by some patient's relative. Leave. Right? So you don't need, it doesn't mean that you have to be calm and be present always. Next is there is a communications framework to acknowledge emotions and express empathy. And this is a very good thing. If you can name the emotion, I see you are angry. I know you are upset. Please calm down. Okay, so these things are really very important. So there is something called the nurses framework, which we will go through later. Just like the Spikes protocol, there is a nurses framework, and there is something called a Pearls framework. So Pearls framework is for relational communication. Relational means two people who are in a relationship. That is your doctor-patient, or it could be a doctor-nurse, it could be a principal with the student or something like that. So this Pearls framework has partnership, empathy, apology, respect, legitimizing, and then support. So these are some of the examples of what could be in all these things. So PEARLS is the framework for relational communication. The third part of this is to understand the root cause. Many times when there is this emotional thing, you forget what the main reason is. So you need to ask some question like, can you tell me what's worrying you most now? See, the thing is, the patient may be worried about not being able to pay the bill. That might be his main worry, and that might come across where he is irritated and he comes out as being very much angry and so on. So listen without interruption, and of course you need all the other aspects to it, like don't look at your phone, put your phone away, and so on. So people generally de-escalate if they feel that they have been heard, and that's very important. You also need to respond with clarity and honesty. Don't use medical jargon. Most people don't understand. And then don't give false reassurance. So this clarity and honesty is very important. You also need to set boundaries. You cannot have a conversation when somebody is yelling at you, or somebody is pointing a knife at you, or someone is crying. So if somebody is crying, best thing is, I know you are upset, please sit. We'll take a minute till you can be better and stop crying. If you have a box of tissues, the one thing in my office which finishes very quickly are boxes of tissues. I think I run through 3 boxes a month. So you please sit, please finish crying, and after you get yourself in hand, let's talk. Or you are very angry, you need to respect me. So this is very important, you need to set boundaries. And then of course at the end you need to debrief and reflect. What did we do right? Every encounter is an opportunity to learn. So you must take time to process this. So these are the 6 points for handling difficult scenario, the structured approach. Stay calm, use a communications framework like PEARLS or it might be nurses. Understand root cause, respond with clarity and honesty, set boundaries if needed, and then you have to debrief. Okay? So the whole focus is on conversation. It's the other things are just, like it's not even icing, but the other things are very, very superfluous. So that's what I'm going to be talking about today. So why are these conversations challenging? Most of these conversations are high stakes, especially if it comes to clinical conversations. It will be high stakes. It depends on whether the person is going to live or die, whether they can pay the bill or not, whether they have to go to a higher center, they can't afford it, such things. It is also emotionally very intense, and you don't have infinite time. If you are a doctor and you have so many patients, you can't sit and spend 2 hours, talking, having a difficult conversation. So there is a time constraint to it, and sometimes the clinical realities also overlap. So for these reasons, these conversations are very, very challenging. So then what are the components of difficult conversations? I wanted to ask the audience, but I think the audience wants me to finish as early as possible. So the components of difficult conversations are, first is differing perceptions. We all look at the world through our own lens, okay? We also assume things about intent. Mostly our assumptions are wrong, and patients will assume like that. Many times if I simply call somebody to my office, they think I am calling them to give them a good scolding. I know people who have come, ma'am, I was so scared. Why are you scared? I'm just calling you to have some conversation about something else. So you assume the worst, and of course there are a lot of feelings which are involved, and then we also like to blame people. So these are 4 things which make difficult conversations really difficult, and we need to understand that. This is what causes the emotional dynamics in these clinical encounters. Now I love this drawing because this giraffe is seeing the top of this lady's hat, and so the giraffe is able to draw only that, okay? And this is exactly what differing perceptions are. We often view each other's situations through our own lens, our own knowledge and things like that. So for example, a physician may think this is a very, very rare, but this is a manageable complication. But the patient may think, but I was never told about this. So you should emphasize, as educators, you have to emphasize to listen without defensiveness. And students should be trained to elicit and validate the patient's perspective. This is very important. Now there is one other thing. Perspective is more important than perception. So if you look at the first one, the 6 and 9, the perception is both, one says 6, one says 9. The perspective is both are right, both may be right, okay? Similarly, the other thing is, the perspective is that both have not been saved, because what can one do in an island where there is nothing and you can't even escape because there is only one boat? So perspective is more important. What is this perspective is what you are looking from outside. And sometimes when you are in this very emotionally charged conversation, it's very difficult to get perspective because we are only looking at the perception. Then people often assume, as I said, bad intent when nothing exists. Very commonly there will be a busy surgeon, he would have operated on somebody the previous day, he'll come open and say, are you okay? Yeah, I know, my team is saying you're fine, good, then we'll see whether we can discharge you tomorrow, and go. The perception is, what is this fellow? I am paying so much to get this operation done, it can't even spend 2 minutes with me. Okay? So this is different perceptions. So you need to train students to clarify your own intent and ask about the patient's interpretation also. And reflective practice will help identify and check these assumptions. Then of course feelings. All these feelings, and Professor Rao gave a very good list of all the feelings which one could have. So all that will go unacknowledged. So a family member may become angry but is actually grieving, or a student will feel very defensive because the student feels that it is reflecting on her worth as a future doctor. So you need to teach emotional intelligence. You name the emotions, you validate it, and you address this. This is very important. And of course, we can use role plays, or you can use standardized patients to practice this, and also constructive feedback processing. The last of this is blame versus contribution. So we always like to blame somebody. This is not my fault. This is somebody else's fault. Okay? But we need to think what led to this. And very, very commonly, medical errors. Medical errors, you always want to blame somebody else for it. But there could be, like they say, the Swiss cheese effect, there could be a series of things why it led to a medical error. So we need to teach students about the difference between blaming something and the responsibility. And case-based learning is excellent for teaching this. And also the monthly mortality morbidity meetings. Unfortunately, monthly morbidity mortality meetings usually become naming, shaming, blaming. That is extremely wrong, because this is an excellent opportunity to learn, right? So the components of difficult conversations are 4: differing perceptions, assumptions on intent, emotions or feelings, and then blaming versus contribution. Now, so what are the core communication skills which you can use? The first thing is you must make it safe to talk. You cannot have a good conversation if the patient doesn't feel comfortable. And this was also told in the last session. So you need to embrace mutual purpose and offer mutual respect. Supposing the other person gets you wrong, you can use something called a contrasting statement. So a contrasting statement is nothing but a statement which clarifies your intent by contrasting it with what you didn't mean. So what you mean and what you didn't mean, both should be there. So look at this. I don't want you to think and that I don't appreciate your hard work or that I'm unhappy with your overall performance. What I do want to address is that you have not submitted this report, or something like this. I'm not questioning your dedication or potential to become a surgeon, but right now your consistency and precision of your surgical techniques needs more work. So this is what is meant by a contrasting statement, so that you are both on the same page. The second one is, of course, to listen. Unfortunately, Indians, we like to jump in and we don't allow another person to talk. We love to jump in and keep on saying something. So seek first to understand, then to be understood. So how do you listen better? There are, of course, huge number of lots of good advice, but I would like you to focus on ask open-ended questions so that you are able to understand this person and paraphrase. Whatever you have said, whatever the patient or the student has said, try to say that and ask, is this what you meant? And acknowledge other person's feelings. So it's important that we learn how to listen better. And then you can adopt one thing, yes and. That is, your view is also right, the other person's view is also right. It doesn't mean that either this or that. Both views can be right. So listen and listen to the other person's view as well. So you need to express your views as well. So don't cut short on that. I understand you don't trust doctors, but doctors are only humans and sometimes they also make mistakes. So this is what you understand their view, but you have to tell your view as well. And then the fourth one is use I messages. The moment you say you, that means it means you sound very accusatory and blaming, and it causes a defensive response. So start sentences with I. These are much less inflammatory. Okay? Right, and the last one, focus on contribution, not blame. So how did we each contribute to this problem? And the purpose is that we don't repeat the same in the future. So the 5 tools are: make it safe to talk, listen, adopt yes and, that means both points of view you have to accept, use I messages, not you messages, focus on contribution and not blame. So then, as Professor Rao said before me, you need to prepare for a difficult conversation. So first thing is, decide whether you actually want to have the conversation. You don't have to, like they say, no, you don't have to win every battle. So be certain you want to have a conversation, that it's worth having. You need to anticipate the emotions, gather facts. Sometimes if you walk into a difficult conversation without facts, you'll have egg on your face. And then choose the right setting with privacy and proper ambience and so on. So then I told you about this nurses model which I said. So the first thing is, the N stands for naming. So you name the emotion, that's most important. Then you understand. So you say something like, okay, what you have said helps me understand this. So convey acknowledgement of what they are saying, but you should avoid saying that you understand everything. Then respect, and then support and explore. Okay. So it's important, naming, understanding, respecting, supporting, exploring, and then silence. Silence is very, very powerful to use during any kind of discussion. So any model you can use, whether you want to use nurses or you want to use pearls, it's up to you what you want to use. So as educators, how will you handle these situations? First is, you need to model emotional awareness and regulation yourself. Your own emotions may have to be discussed calmly and openly. Sometimes you might lose your temper with a patient. Come back, discuss it with your students. That was a tough case. Show appropriate vulnerability. If you lose a patient, you might feel, it might show on your face, and there's nothing wrong with that. So you need to show to your students that it is normalized to have emotions. Then create psychological safety. There has to be a learning environment where students will feel comfortable to talk to you. Express uncertainty. If they think every time they are coming and telling you something that I want to yell at them, no one is going to tell you anything. Then avoid being judgmental and use non-defensive, open-ended responses. Use reflective practice tools. Again, I think Chaitanya did a good this thing with that. So structured debriefing after emotionally intense scenarios. Encourage journaling or reflective writing. Teach self-care boundaries. I'm sad, but in India we all think that if we seek mental health, if we seek psychological support, if we seek psychiatric care, that something is wrong with us, that we are a mental case. And that's wrong. So you need to teach your students that it is okay to seek support, that it is okay and you should discuss strategies like mindfulness, timeouts, compartmentalization, professional supervision, and so on. And then, if there is a crisis, respond to that. If a student is having a crisis, an emotional crisis, respond to that. Academics can wait. Okay? So we need to be very much aware what to prioritize over academic objectives. Right? So these are the strategies for educators to handle these situations, especially with students or postgraduates. So then the last thing I am going to tell you is how to teach medical students these skills. Of course, you can use simulated scenarios with emotional weight. We almost never make our OSCEs with some emotions thrown into it. Our simulations are always about medical errors or some protocol. It's never about adding emotions to those protocols. Follow debriefing with communication and emotional processing. You need to teach the language of emotions. As we said, encourage them to name and reflect on the emotions. What did you feel when the patient was crying? What did you feel when the patient died? So it's important that students are able to name and reflect on the emotions. And promote empathy without emotional over-identification. Normalize emotional responses Especially if faculty can tell some stories about, some narrative sessions, how experienced doctors manage feelings, and then don't throw them in the deep end of the swimming pool. Students should not be thrown into high stakes emotional encounters. They should be led slowly, and then we have to provide increasing responsibility at each step. And then of course you can add assessment which has an emotional intelligence component to it. So these are things which you can add to your assessment. So these are the 5 ways in which you can teach medical students these skills. 5, I would say, common ways, but there will be other ways in which you can teach. You can simply put up a photo like this and ask them what is it. People can only see people who are angry or mad. They don't know all the things which you feel inside. You're tired, you're confused, sad, embarrassed, hurt. All these things are below the surface, and doctors don't have the luxury of expressing their emotions to patients. So that is something which we need to tell our students. So I'm going to finish this by doing a small scenario with Dr. Chaitanya. Dr. Chaitanya is going to come here and be a patient. He's going to be Mr. Thomas, and I'm going to be the surgeon, who is Dr. Sita. And the context is that Mr. Thomas underwent a routine surgery to remove his appendix. Post-operatively, they left a small sponge inside his abdomen. So this required a second minor surgery to retrieve it. So let's see. I want you to listen to this sketch and tell me what went wrong, okay? And this sketch was prepared by ChatGPT. I didn't do this. Mr. Thomas, just a quick update. There was a bit of an issue during our surgery, but nothing major. Just a sponge that was accidentally left inside.
What? Wait, a sponge left inside me?
It happens sometimes. It's important that we caught it. You'll need another small procedure, but it's very routine,
That sounds like a serious mistake.
Well, things don't always go perfectly in medicine. These things are rare, but this is not unheard of,
But I could have gotten an infection. This is unacceptable.
Look, I understand that you're frustrated, but the important thing is you're fine now, no? So we are moving forward and we are fixing it.
You are not even apologizing?
Look, we are taking care of it. Let's focus on what's next, not on what went wrong.
This feels like a cover-up. I think I will sue you.
That's not fair. Come on, we have protocols. We were doing our job. Yeah. So what went wrong here? Anyone? Yes? He didn't apologize. She didn't apologize. What else? Did not even accept. Yes, was very defensive. Did not even accept.
Compensation.
There was a communication gap. Yes. So basically these were the key issues, no? She was very defensive. She minimized the thing. Okay, she ignored the emotional impact and loss of trust. There was no apology. That was exactly what you people said. She didn't take responsibility. She's just saying, let's focus on what's next. And she's trying to escalate the thing. When Thomas is saying, no, I will take legal action, Sita is responding, that's not fair. The physician's role is to de-escalate and not to argue. So this conversation highlights breakdown of professionalism, accountability and empathy, which are very critical of ethical and effective communication in medicine. So we are going to redo the same thing, and I request Dr. Chaitanya to please come up. So Mr. Thomas, I want to thank you for taking the time to talk with me. There's something important I need to discuss with you about your surgery.
Is something wrong?
Yes, and I want to be honest and transparent with you. After your surgery, our team reviewed the surgical counts and post-operative imaging. We discovered that a small surgical sponge was unintentionally left inside your abdomen.
What?
I'm so sorry, Mr. Thomas.
Are you serious? That sounds like a huge mistake.
I can see you're shocked and upset, and that's absolutely understandable.
How could something like that happen?
You're right. to be asking that. If I were in your position, I'd feel angry and confused too. We take this very seriously and I deeply regret that this happened.
I trusted you with my life, and now you are telling me that you left something inside me?
I truly respect how much trust you placed in us. That trust matters and we let you down. I'm so sorry.
So what now? What does this mean for me?
We are going to take care of this immediately. The sponge needs to be removed and we've scheduled a minimally invasive procedure to do that. It should be quick and uncomplicated. Our hospital will cover all related costs. We'll also ensure that you are supported physically and emotionally throughout this.
Will this affect my recovery?
That's an important question. Would it help if we talk through the recovery process again, including what will change and what won't?
Yes, please.
Thank you. So now, this was the redone version. So here you have this nurses protocol, naming, understanding, respecting and all that. Can you tell me in this, which of this nurses thing is there?
Sponge counting.
Pardon?
Counting of sponge.
Counting of sponge. Naming, yes, naming is this. So Sita is saying, I can see you're shocked and upset. She's naming the emotion. Okay. Yes. Understanding is this, isn't it? Because she's saying, if I were in your position, I'd feel angry and confused too. So that is understanding. What is this? Respecting, because that is very clear. Yes. So she's saying that we will support you. And she's saying that we will pay all the costs also, isn't it? So that is good support. And then, what is this? This is exploring, allowing him to ask more questions. So this is some of the ways in which you can redo. Many times it will be very quick, so you won't have time. So this approach works because it acknowledges harm was done. There is a clear plan. It shows empathy. She takes responsibility. And you avoid defensiveness. So Yuval Noah Harari is my favorite author. And he says that the most important skill for the 21st century is emotional intelligence. This is emotional intelligence, where you need and you know why it is important also. Because not just you have to understand your emotions, but you have to recognize and influence the emotions of others. And these are the 4 pillars: self-awareness, self-regulation, empathy and social skills. You can ask yourself, do we have these qualities? More importantly, we need to inculcate these qualities in our students. Extremely important. And with that, I will conclude by saying handling difficult conversations and emotional responses is a core clinical skill. It is very challenging because of the high stakes, time constraint, clinical realities and so on. And there are some simple tools which we can effectively use as a model. One is nurses and you can use pearls, both are useful, and there are other models as well. The strategies need to be developed and honed over time, and emotional intelligence and its 4 pillars are very vital skills for this century. So knowledge decides what to say, skill decides how to say, attitude decides how much to say, but wisdom decides whether to say it or not. Thank you very much for a very patient hearing.
Thank you, ma'am, for your thoughtful and really impactful session. We would like to invite Dr. Jagati Nagari, ma'am, ME.